Hello, it's Michelle Fennick here, and this presentation is on the anterior ankle. What we'll cover in this presentation is an overview of the ankle. We'll discuss the joints of the ankle because it's really important for us to know our relative joint anatomy, anterior ligaments and anterior retinacular, anterior nerves, and then our anterior tendons. Just before we start, it is always important just to refresh our bony anatomy of the ankle and foot, and it's good to know that our hind foot consists of our calcaneus and our talus, then our midfoot consists of our navicular, which is medial, our cuboid, which is lateral, and our three cuneiforms, which run from medial to lateral as 1, 2, and 3, or medial to lateral. You can see these from the lateral aspect of the foot, where we can see the calcaneus, cuboid, and fifth metatarsal, along with the fibula, and we can see a bit of the talus. And then the medial aspect of the foot, we can see the tibia, the talus, the calcaneus with this sustentaculum tali here, the navicular, the medial cuneiform, and the first metatarsal. If we look through a coronal section of the foot, which is taken through this way, we can see the different joints that exist. So we have the ankle mortise joint, or the talocrural joint, which exists between the tibia, the fibula, and the talus here. Above that, we have the inferior tibiofibular syndesmosis. Syndesmosis is just a fibrous joint between the tibia and the fibula. And then we have the subtalar joint, which, as its name suggests, sits below the talus. So it sits between the talus and this is the calcaneus down here. So here's our talocrural joint, or our ankle joint. The ankle mortise is made up of this fibula, the bottom part of the tibia, and the lateral part of the medial malleolus. And it's a hinge joint, and it transmits a lot of the weight and force through the lower leg to the foot. And it's important. It allows dorsiflexion and plantar flexion. We can also call plantar flexion extension. So flexion and extension of the foot. If we look through the talocrural joint, we can see the lateral malleolus, the medial malleolus, and this is the talar trochlear surface of the talus. And then this is posterior and this is anterior. It's really important anteriorly for us to appreciate all of these structures, and we'll go through these in this presentation. Here you can see a axial or transverse MR through the anterior ankle, which is this section, and you can see the fibula, the tibia. We can start to see a bit of the retinaculum, and this probably should be called the superior extensor retinaculum here. We can see the tibialis anterior, extensor hallucis longus, and extensor digitorum longus tendon, and this here will be a bit of the muscle that's associated with this, but we also will have our neurovascular bundle, which will sit in here as well. We must look at the anterior joint recess, so it's important that we appreciate that anatomy. It's this area that sits in here between our tibia and our talus. So we can put the probe on in long axis here, get an image of the tibia and the talus, and we should see this cartilage that overlies the talus. If we angle upwards, we can sometimes see cartilage underlying the surface of the tibia as well. So we have an extracapsular fat pad that sits within this anterior joint recess, and we need to see that as a nice homogeneous structure. It can get elevated and moved out of the way when there is an effusion that sits in there. We should look at it with the foot in neutral and then dorsiflex and even plantar flex the foot to see if any fluid shows up in this area. We should look for any bony irregularity. There is an accessory bone called the os talotibiale, which can sit in there, although it's controversial whether that is an accessory bone or whether it is an old avulsion fracture, which is probably the more likely thing that it actually is. Here you can see that we look at the foot in neutral and then dorsiflexion, and the fluid can become a little bit more obvious. It's a bit harder to put the probe in there. You need a bit of gel. Plantar flexion is easier, but I would encourage you to look at this anterior joint recess with the foot in this position. And you can see when there's a fluid there that the fat pad becomes elevated and more superficial. So here you can see the anterior joint recess. You can still see the cartilage overlying the talus there, and you can see some fluid and the elevation of the fat pad. Here's the fat pad here, which is elevated due to the joint recess fluid. Be careful of your pediatric anterior joint recess. There's cartilage that sits over the lower part of the tibia here that hasn't fully ossified, and you don't want to mistake that for fluid. And you can see the little fat pad sitting just here and the cartilage sitting over the talus as well. So there's actually a fat pad here and a fat pad here, and as I said, they should be homogeneous. Remember, the bony margins should be nice and smooth, and remember you can look at the talus in short axis too and look at the smoothness and the thickness of the cartilage over the talus in that plane. So remember to look in two planes. You can get signs of anterior impingement, which we can get in soccer players and ballet players, which are pointing and then extending and dorsiflexing their foots or feet a lot, and so we're looking for any sort of little what we call kissing areas of osteophytes that can sit in this area here. So this is called the kissing lesion, where it looks like a pair of plump lips coming together. And with that, we can see hypertrophied cartilage, and the cartilage will look all irregular. The fat pads will look all heterogeneous as well. The same with the tibia we looked at. Remember to get used to looking at the pediatric fibula, get used to the joint plate, and then the cartilage that overlies the distal end of the bone. Which you can see here is the tibia, and often there's a bit of irregularity as it's starting to ossify, and you just need to get used to looking at that to know that that's normal. The subtalar joint, as I said before, it sits between the talus and the calcaneus, and it's a subtalar joint that allows inversion and eversion, with inversion being a lot more easier for us to do, and inversion is the position of the ankle that your foot and ankle usually go into when you do a sprain, and it stretches the lateral ligaments. We've got to know the surface anatomy of our anterior ankle, because if we look closely enough, we can see some structures that we may not have appreciated before, such as the superficial peroneal nerve, which we can see being outlined here. I've just pointed these out. If there's anyone's ever had an arthroscopy that you're encountering in the ankle, this is where the portals lie, and you can see some subcutaneous changes that sit deep to where these portals sit. So they sort of sit more anterior to the lateral and the medial malleolus here, and just lateral to the extensor digitorum longus tendon, and just immediately medial to our tibialis anterior tendon. There are other joints associated with the ankle, and that is the inferior tibiofibular syndesmosis. So remember, I said before, here's our ankle mortise or talocrural joint, and it sits above that, so between the distal tibia and fibula. We have a proximal one up at our knee, and so we call this the distal inferior tibiofibular joint. We have the interosseous membrane that runs the length between the tibia and fibula, and we can see a little bit, it actually does extend a little bit more inferiorly than it's demonstrating here, and we can see that on ultrasound as well. So as I said before, it's a fibrous joint, and it's held together by fibrous tissue and ligaments, and there's a few ligaments that hold it together. The interosseous ligament, which is just a thickened end of that interosseous membrane, then the AITFL, which is the anterior inferior tibiofibular ligament, which is anteriorly, then the PITIFL, which is posteriorly, and what we call the transverse ligament, which is really a component of this PITFL. I'll just really focus on the AITFL and the interosseous membrane in this presentation, because we're just looking at the anterior ankle. When someone injures this syndesmosis and injures the ligaments with it, we call it a high ankle sprain. So high ankle means it's above the level of the ankle joint. And if you're seeing bruising above the level of the ankle joint, particularly laterally and swelling around here, they often have retinacular and syndesmotic change. And it's important to note because it's often not picked up clinically and it's often missed, and we do need to manage it differently. And these injuries can go on and on and on and cause lifestyle limiting changes to the patient. So the AITFL is the anterior inferior tibiofibular ligament. So here's our fibula, here's our tibia. It's above the level of the ankle joint, and there's multiple bands. There's usually about 2 to 7. Most commonly we'll see about 3. On most people I see about 3. And so you can sort of see on this one there's 1, 2, and 3 here. This one you can see that there's multiple. But this lower part of the AITFL is called the Bassett ligament, and you can see it actually sits over the talus, and it's because of this that it can actually get impinged. So if you imagine the foot dorsi flexing up, this can get caught, and that can be when it gets caught, it sort of gets compressed rather than actually torn by being overstretched. But it can have the same sort of appearance as a partial thickness tear on ultrasound, which means it gets thick and it loses that fibrillar echo texture of the ligament. And so we really need to be making sure that we're assessing all these bands of this anterior inferior tibiofibular ligament. When injuries occur, only one of these bands may be injured, and this Bassett ligament is much longer than these other ligaments, and they can all be different thicknesses. Generally, people have the same number of bands on each side, but there's still studies going on to determine this. We need to know how to assess this syndesmosis in the AITFL clinically, and what we need to do is really dorsiflex the foot up and then turn the foot out to the side this way, and that's really called the external rotation test, and that's basically what we need to do when we're scanning. We can also check to see if they're getting pain there by squeezing the tibia and the fibula together, more often up in this fleshy part of the calf, and we can do a crossed leg test where it really, when you put the more fleshy part of the calf over the thigh here, and then you push down on the ankle, and you see if they get any pain in the region of the AITFL. And that sort of gives you an idea if there's pain or a bit of laxity going on in that area. So to scan it, I would dorsiflex the foot up and then turn the foot to the little toe side, and that puts as much stress on the AITFL. This is looking in short axis to look for the number of bands, and as you can see, that's quite difficult. Often scanning through from superior to inferior in long axis is actually easier. But we do need to not scan the foot in this position, but dorsiflex the foot up, turn the foot to the little toe side, and you'll see this stretch right out. And so we need to look at it extending from the tibia to the fibula to the tibia. And the Bassett ligament, the inferior one, can be really quite long. And so don't underestimate how long that ligament can be. This is the ligament here from here to here. Ligaments have an outside bit of them called an epiligament. And if you see the ligament well enough, you'll see an echogenic portion right on the outside. But this ligament here has got a nice fibrillar echo texture, nice smooth bony margins that it's inserting into, and it looks quite nice. It is important that we examine all bands. So this is the upper band, this is the lower band, and this is a middle band. You can see the lower band's a bit longer. They all tend to look the same. You can see the thickness of them is roughly around the same. Here's the Bassett ligament here. You can see it's quite long. I've got it zoomed up so it's not so clear, but it would extend from about here to here. So it's quite a thin band. So you can see the ligament extends from out here to right over here. In children, it will look a little bit different. It will actually go over the growth plate of the tibia, and you can see how long it is here and how thin it is too in the pediatric patient. When there's injuries that occur to this AITFL, so ligaments can be either overstretched, have a partial thickness tear, or be a full thickness tear, we tend to say ruptured with tendon and a full thickness tear with ligament, and avulsions at the tibia and fibula insertions are quite common with injuries to this AITFL, as you can see here. And so we're looking for thickening of the ligament and avulsions and disruption of that fibrillar echo texture. So a full thickness tear, you can get like what we would call a rupture, a complete tear of the two ends and discontinuity of the ligament. You may not have laxity with the joint at that stage because there are other bands, and you may only fully tear one of the bands. And this is really important to comment on because this is where the clinical testing and the imaging findings need to marry up. So try and say if there's a normal band and then there's an injured band, usually the inferior band is the one that will get injured first because it's longer, it sits over the joint, and it's more likely the one to get some avulsion injuries associated with it. You move the probe up a little bit higher into the ankle and you can assess the interosseous membrane, which should look like a thin layer that should not be interrupted. Generally, if it's interrupted, you'll have changes to your AITFL here, which you can see your AITFL sits fairly nearly vertical in orientation. And the interosseous ligament is more the distal thickening of that interosseous membrane. So the anatomic classifications of it are not quite clear and probably need more clarification. When the interosseous membrane is injured, it will become fuzzy and thickened and you won't see it very clearly. So it is important that we look up between the tibia and the fibula and make sure that we can see it nice and clearly. And if we're seeing this, we press on it and we determine if that is the source of pain. The probe pressure, particularly with an acute and recent injury, is quite an important tool that we can use. So here we can see some fuzziness and discontinuity and maybe not even see the interosseous membrane. We won't go over the PITFL. We can see it sonographically and we can see the transverse ligament as well, but we don't have time to go over that. The Dupuytren fracture is a fracture that can occur to the interosseous membrane, and it can occur to syndesmotic ligaments as well, and it's usually associated with fractures. We can also have the Mason-Eve fracture, which tends to tear that PITFL. So you need a fair bit of force to do that, but you will often get a fracture up higher in the fibula. So it's often important that we really extend our scan up the length of the fibula to look for any sort of other fractures up there. We do have the anterior tibial artery, and sometimes that can laterally deviate and sit across the AITFL. So sometimes we can see that sitting there. Sometimes we'll see branches of the anterior tibial artery that sit across the AITFL, more likely this anterior malleolar artery. Another ligament that we may need to consider anteriorly is our dorsal talonavicular ligament. And so that sits between the talus and navicular. It's a bit more anterior in the foot, and changes with this are quite common. We can see it sitting here. It sits in about this position, and so we would normally have a look at it in long axis with the probe like this. And so we're looking between the talus and the navicular. So it sits in the more anterior portion of the foot, because laterally we're going to hit more our calcaneocuboid area. The superior and inferior extensor retinacula are important structures to appreciate, and their anatomy is really complex. As you should know, retinacula are bands that hold tendons and structures in place and aim to hold them in place, but can also be structures that can compress and cause entrapment of certain tissues, particularly if there's changes deep to them. So any bony changes or changes to ligaments overlying the bones here can cause an upward pressure on these structures. When they're normal, we can scan over them and completely not appreciate them. And we can do that when they're abnormal as well, because if we're not sure that they're sitting there, we can completely forget about them. So, you know, a normal thickness of a retinaculum might be 0.5 of a mil, and when it's thickened, it might get double that, so it might be only 1 mil. So we might just think that it's a normal structure when in fact it's thickened. The superior extensor retinaculum is easier to understand. It really just runs from the fibula to the tibia, and it braces the distal leg and just above the ankle joint. And it's continuous really with the superior perineal retinaculum and then the flexor retinaculum. So it does cause this bigger case, and we tend to think of them more in isolation, but we need to think of them as being connected. The anterior tendons run deep to this, except for the tibialis anterior. And it's confusing because it may or may not have a completely separate tunnel that's formed by this superior extensor retinaculum. So in some cases you will see the tibialis anterior sitting deep to it, and in other cases you will not. And we need to start appreciating this so that we're more certain of when there's an injury. And so here is a tibialis anterior tendon, and we can see the superior extensor retinaculum running superficial and deep to it. So it can sit in a tunnel. And if we go looking at it with a hockey stick probe, we can sort of appreciate the extensor retinaculum running around this tibialis anterior tendon. If we look at some MRs, here's an MR, and this is in the region of the tibia and fibula, so we're above the ankle joint. So this is our superior extensor retinaculum, and we can see it sitting over the tibialis anterior tendon. And in this patient here, we can see it sitting deep, but not sitting superficial. So there's quite a bit of variation in this, and we do need to appreciate that so that we might not say when it's missing that it's completely gone and torn. The superior extensor retinaculum, when it's there, we can measure it. We can see it either sitting over it or over the tibialis anterior or under it. We should look at its insertion onto the tibia and then its insertion onto the fibula, which should be nice and smooth, and there shouldn't be any bony irregularity or avulsions. We can look at it in short axis. So this is it in short axis, so we can see the tendon in long axis, the tibialis anterior deep to it, and you can see how thick it is there. Some people it will look thicker, generally in males it tends to look a little bit thicker, and you can see this has a superior and a deep component to the tibialis anterior, and you don't want to confuse this for tenosynovitis. When there is an injury, it's quite subtle. So this is a retinacular injury, and you can see there's fibres that sort of stop and there's a gap in here, and so there is a tear of the retinacula. So when they have an injury here, they'll present like this with this thick band, and you can run your finger down and it does this big speed bump over this retinacular area. You can see it right here, and it becomes thickened, but if you don't know it's there, you may not notice that it's injured at all. And it's important because it can cause little fractures at the insertion onto the tibial and even the fibular margin, more often onto the tibial margin, and it can really add to the rehabilitation time from this injury for this patient. The inferior extensor retinaculum, this is a much more complex structure and it's quite tricky to get your head around. It's called Y or X shape. Different people will have different components, and so it's got these different components that I won't go into now, but it's got all these different limbs. So you can see it comes up onto the tibia here, it comes down really more laterally into our sinus tarsi, and then medially it can come down onto some of the medial portion of the subtalar joint as well. And we can see it sonographically, and we can see it extending from the medial malleolus off and following it, but it does blend with other aponeurotic structures. So it doesn't just extend from bone to bone, it extends from bone to other ligamentous tissues, other fascia, and all sorts of things. So with the inferior retinaculum, you're not just looking for it from bone to bone, and that's really important to appreciate. It's thinner in some people in the superior extensor retinaculum. However, when you follow it down further into the foot, you can see it loop around the extensor digitorum longus. And this is important to appreciate because you might start to call this tenosynovitis. And it's important that you can appreciate that this is actually just the inferior extensor retinaculum, and it can look hypoechoic because of anisotropy, but we can still see little fibres and things sitting in there. This was an injury where the inferior extensor retinaculum tore and it's not looping fully around the extensor digitorum longus, and there was a whole lot of swelling down here. And so you can see on this one how it came back and looped around, and on this one it's come down but it's torn between here and here. There are nerves in the anterior ankle, and nerves are the area that we need to get better at. The anaesthetists are getting fantastic at looking at nerves, and we need to make sure that we're incorporating them into all of our scan protocols. It's important for us in the anterior ankle to appreciate the anatomy of the common peroneal nerve, which we know sits up near our fibular head. Now remember, our common peroneal nerve is a division of our sciatic nerve. Our sciatic nerve divides into our tibial and our common peroneal nerve. So that happens up in the back of the distal thigh. And then the common peroneal nerve runs around to the lateral aspect of the leg, and it loops around the fibular head, and then it divides into a superficial and a deep peroneal nerve. And so the superficial nerve is going to stay more on the lateral component of the leg, and the deep peroneal nerve will come more anteriorly, and it travels from lateral to more anterior. So the superficial peroneal nerve, it's the one that stays more more laterally. So it comes around the fibula, and then it courses within the peroneus longus muscle. And then it emerges from the peroneus muscle midway through the leg, and then it will actually come out and pierce through the fascia between the extensor digitorum longus and usually the peroneus brevis muscles, but we'll have a look at that, and that should say deep to the fascia. So then it's going to pierce the fascia and come through, and it pierces the fascia about 10 to 15 centimeters above the ankle, but this is quite variable, and then it becomes subcutaneous and it sits more on the lateral aspect of the foot. So our superficial peroneal nerve, it supplies more this lateral part of the foot, and our deep peroneal nerve is quite specific. It supplies this lateral aspect of the big toe, the medial aspect of the second toe, the web space in between, and a bit of the dorsal area of the foot. So the superficial peroneal nerve, you can see it's piercing the fascia here, and then it will divide into a medial dorsal cutaneous nerve and an intermediate dorsal cutaneous nerve, and then it runs over the foot. Remember, I showed you we could see the surface anatomy of this nerve before because it's very subcutaneous, particularly in people that don't have much subcutaneous fat. We can see it between our extensor digitorum and peroneus brevis muscles sitting just here. So it's still deep to the fascia, and it's just about to pierce the fascia here. So we can see it here between extensor digitorum longus peroneus brevis. This is our fibula here. And then it can course over, and we're going to follow it as it comes over this dorsal anterior aspect of the foot. It can get some entrapment as it comes through the fascia here, and it can get some rubbing with dancers, and we can get some swelling of the nerve at this point, and we can get swelling of it if it gets impinged externally from even shoes and boots and things like that. And so you can see a secondary neuroma develop. And it's important, it's hard to see as it becomes superficial, but if someone's got some pain there, we do need to assess it. And you can see that this is a subcutaneous layer, and it sits in here, and it branches off, and it can have little divisions. And it can be very tiny to see, and it sits in the subcutaneous tissues, and it blends with those. So here's the fascial layer, and it sits superficial to that. The deep peroneal nerve, don't get confused between this. This is really easy because it's the nerve that runs with our anterior tibial artery and then our dorsalis pedis artery. And so really we can follow that by following the neurovascular bundle. It really sits up in the calf deep to our extensor hallucis longus muscle belly. And so here's our tibialis anterior, and here's our deep peroneal nerve. And so that's a really good landmark to look up in the calf. And then if you find it there, you can just follow it down into the ankle. It also, you need to know what our anterior tibial and dorsalis pedis artery is. Basically, once it crosses the ankle joint, it becomes dorsalis pedis artery. And so that's just so that you know what structures you're calling, if you're calling it anterior tibial artery or dorsalis pedis artery, when you're looking at this deep perineal nerve. So we can see it in long axis and we can see it in short axis. So here's the anterior tibial artery, and it sits in all different positions relative to this. So you have to go looking with a high frequency probe with your focus set properly to see it nice and easily. It actually changes position relative to the tendons as it moves through the ankle. I sort of drew this. I don't know if it makes much sense, but proximally you can see it sitting between tibialis anterior and extensor hallucis longus. Then this is the tendons, not the muscles, and then it's going to sit deep to our extensor hallucis longus tendon, and then it ends up sitting between our extensor hallucis longus and extensor digitorum longus tendons in more the part of the foot. It gives off branches, so it gives off branches deep to the inferior extensor retinaculum. And it's important that we know that it sits deep to the superior and inferior extensor retinaculum, but particularly deep to the inferior extensor retinaculum, which is this structure which we can see. This is normal, there's nothing wrong with it, but you can see how thick this is when we actually go looking for it. Why I'm mentioning this is because there's a tunnel called anterior tarsal tunnel syndrome. We tend to call the tarsal tunnel the medial aspect of the ankle, where our flexor tendons run through and our tibial nerve runs through. So that's called the tarsal tunnel. But our anterior tarsal tunnel is the anterior part of the ankle, and it's sitting deep to this inferior extensor retinaculum. So here's our inferior extensor retinaculum. Here's our anterior tibial artery, just about to turn into our dorsalis pedis artery, and we can see just a normal division of our deep perineal nerve happening here. We can get a bit of impingement of the deep perineal nerve that happens deep to the inferior extensor retinaculum. This is called anterior tarsal tunnel syndrome. And this usually, if you're going to pinpoint a point where it happens over the dorsal talonavicular joint. And remember, we looked at the dorsal talonavicular ligament before, so it's in that area that we're going to be looking at it. We're going to get numbness in the area where that perineal nerve innervates. So remember, it's between the first and second toes, basically. And so all in here, which is where it runs to. This is it coming and emerging here. The anterior tarsal tunnel will happen, as I said, over the dorsal talonavicular ligament, which is about this point. So we have to be careful of any osteophytic changes or changes that are happening. So here's our dorsal talonavicular ligament, and that's the nerve that runs straight over the top. So when we get thickening and irregularity of this joint and the inferior extensor retinaculum sitting over the top, this nerve can get entrapped right in this region. So we need to be very aware of that. Here you can see a dissection, you can see the deep perineal nerve. It's gone past the ankle joint, so it's now called the dorsalis pedis artery. You can see where they come, and you can see the nerve coming right down between this first and second toe. I'm racing through here just to make sure I get everything covered in time, but the other part of the anterior ankle that we need to know about and structures we need to look at is tendons. And people are probably more familiar with their tendons than any other part of the anatomy, but we will just go over it again. When I think of the ankle, I really like to simplify it, and this is the way I picture it in my head, is I divide it into anterior, medial, lateral, and posterior ankle, with the anterior tendons being our extensor tendons. And when we say extensor tendons, it's not plantar flexion or extension of the ankle, it's extension of the toes. And these are the flexors of the toes. These are our perineal tendons, and this is our Achilles and our plantaris posteriorly. So our anterior tendons, we know that they sit in relative positions to the superior and inferior extensor retinaculum, with the tibialis anterior sitting in various positions relative to these retinacular structures. And I tend to think of them as Tom, Harry, and Dick, and the neurovascular bundle will change positions relative to these tendons, as I've shown you already. Remember, we also have peroneus tertius, and that sits lateral to our extensor digitorum longus. And all these tendons sit in sheaths. So there's two different types of tendons that have sheaths and tendons that don't, and these all have sheaths. And as I said, they're held in place by these retinacula. Tibialis anterior is the largest, the strongest, and the most medial, and then they run from medial to lateral in this order. And if you like mnemonics, that you can say for the anterior part of the ankle, Tom hates Dick passionately, with passionately being our peroneus tertius. Not to forget that. We should be passionate about remembering this. So all of the anterior tendons are related to the anterior compartment of the calf, and they're called the dorsiflexors, but the extensors of the toes. And when we're up in the calf, we can actually see these muscles, and it's actually good to get used to finding the muscles and then following them down, just in case there is an injury and you need to look at the musculotendinous junctions of any of these. When we look at them in short axis, we need to see their relative position. So we'll see tibialis anterior a bit larger, and then extensor hallucis longus, and sometimes it can be hard to get them all in the one view, so you do need to do a slide around to see them. As I said, they're called the extensors of the toes, so we need to make sure we understand extension and flexion of the toes. So this is flexion of the toes, so we're flexing the toes, and this is extension of the toes. And our ankle tendons, when they've got flexion and extension in them, is talking about the toes, because if you think of the name, it's extensor hallucis longus or extensor digitorum longus. It's talking about the toes that they're extending or flexing. So don't get those mixed up with flexion and extension of the actual ankle. Tibialis anterior muscle and tendon. It is good to know about our tibialis anterior muscle because we can get little hernias associated with this muscle particularly, and it extends from the tibia, the interosseous membrane, and then it inserts onto the medial cuneiform in the base of the first metatarsal. So it doesn't extend down to toes like the other two anterior tendons do. And so because of this, it really just dorsiflexes the ankle and then it inverts the foot. And so you can sort of see it coming down here. This is our extensor hallucis longus, but this is our tibialis anterior here. And it's good to, if you get a chance, to sit and look at where you can see those tendons. So if you have to scan them, you know exactly where they're sitting in the surface anatomy. The tibialis anterior in short axis is quite big. We've looked at it already. It may or may not sit deep to the extensor retinaculum. And so in 25% of the cases, it lies in a separate tunnel. It may lie superficial or it may lie deep to the extensor retinaculum, particularly the superior extensor retinaculum. So we can see it sitting here. It often sits quite close to the tibia. Here we have the musculotendinous junction of the tibialis anterior, which is this structure just here. And you can see that it forms quite early because the extensor hallucis actually forms its musculotendinous junction quite distally, whereas this one forms its musculotendinous junction a bit more proximally. And that's due to how much more proximally that tendon inserts. It doesn't extend all the way down to the toes. As we've discussed, it can sit either in a separate tunnel, it can sit just superior, it may just sit inferior to the retinacula. So this is quite variable and we do need to be aware of that. We can look at it in long axis. Remember, we're going to notice that this is the inferior extensor retinaculum. We're not going to get that confused with tenosynovitis, and the same when we see that position up even over the proximal superior extensor retinaculum as well. So we need to make sure that we do follow it all the way through the superior and inferior retinaculum and then down onto the medial cuneiform. So we follow it all the way down onto the medial cuneiform. We can follow it down a little bit further and make sure there's no changes over the bone here, because if this is irregular, it's going to cause some irritation to the tendon. Changes you may encounter with this tibialis anterior tendon: tendinopathy, so usually as it crosses the ankle joint, tenosynovitis, because it's more common in the tibialis anterior than the other anterior tendons. Ruptures can be confusing because clinically it mightn't look like it's ruptured, but you may see that it's ruptured. And if it happens distal to where it crosses the retinaculum can actually hold it in place and it mightn't retract proximally. So you do need to follow it all the way down to its insertion onto that cuneiform and base of the first metatarsal. You can get partial thickness tears, and looking at that tibialis anterior muscle and that musculotendinous junction are quite important. As I said, you can get muscle herniations, and you can also get atrophy and hypertrophy of that tibialis anterior muscle as well. These muscle herniations generally occur at sites of perforating vessels. The extensor hallucis longus tendon, you can see that it's going to extend the big toe. And when we say extend the big toe, this is extension. Flexion is down underneath, which is quite confusing. So it's extending the big toe, and because this is the movement that it does, we need to make sure that we look at this tendon when we're flexing and extending this big toe. So you often need to passively flex and extend the toe by grabbing the toe and moving it up and down, and do that while you're scanning it. It's going to sit more lateral to the tibialis anterior. It always sits deep to the retinacular. You can see it sitting in here. It's important to look at it in long axis. Once again, don't confuse tenosynovitis with any retinacular sitting over the top of it, and follow it down as it runs close to these tarsal bones. If they're irregular, that can cause some irritation to it. And so you need to follow it all the way down to the hallux, and follow it all the way down to the distal phalanx of the hallux, as we can see here. And you might even need to look to see if there's any avulsions or changes that are occurring at the distal enthesis here. When we look at it in short axis, I mentioned before that the muscle belly extends quite inferiorly, and often people can get that confused with tenosynovitis. So we don't want to get that confused and call it tenosynovitis. Sometimes the muscle belly won't encircle it, it will sit out to the side. So this here is the muscle belly, and here you can see a bit of the neurovascular bundle sitting deep to extensor hallucis longus tendon as well. I mentioned the neurovascular bundle. Remember, we've talked about it already when we're talking about the tibialis anterior and dorsalis pedis and the neurovascular bundle. We're talking about the deep peroneal nerve. And so we're going to look at that with our neurovascular bundle. We can see between our extensor digitorum longus and our extensor hallucis longus, it's sitting in here, but it will move that neurovascular bundle, as I showed you, as you move down through the leg and through the foot. So it is important to note that using relative structures can get confusing unless you know that they're going to move. So the key landmark that we're going to use is our anterior tibial artery, and follow it with that. And the nerve can sit on either side, it can sit superficial, it can sit deep to it. Remember, we're going to look at it in the region of the inferior extensor retinacular, particularly to look for entrapment with that anterior tarsal tunnel syndrome. And the nerve can often be surrounded by fat, which it can just blend with the fat and make it really difficult to see. Which you can see where it sits here in the foot. Then we're finally onto our extensor digitorum longus. So when we're looking at the three muscles, we've got our tibialis anterior, our proximal, our more proximally located musculotendinous junction there, our extensor hallucis longus, which sits a bit more, muscle belly sits more deep, and then our extensor digitorum longus. So the muscle of the tibialis anterior and extensor digitorum longus sit together. And so we can follow that down until it becomes tendon, and then it's going to spread out into different slips that run to all of the different toes, 2 to 5. So when we're looking at it in short axis here, we can see all the different slips occurring here. And that sits over this muscle in the foot called our extensor digitorum brevis, which is this muscle just here. So if you're wondering what extensor digitorum brevis is, that's the muscle that the extensor digitorum longus tendons sit over the top of. We can look at the extensor digitorum longus in long axis, and we're going to follow it down into its different slips, and we can see some of those different slips in the surface anatomy here. And remember, the extensor digitorum longus, when it's in short axis, it has the inferior extensor retinaculum circling around it. So this is the extensor digitorum brevis muscle, and this is the extensor digitorum longus tendons, and this is the inferior extensor retinaculum sitting over the top of it. Here's the different slips that are emerging, and they will all travel out to the different toes. You can see them nicely here. You can watch the toes all moving. The peroneus tertius is often a most lateral slip of this that runs out to the side. And you can see it sitting quite a bit more separately. And this is, once again, our extensor digitorum brevis muscle here. So you can see the separate slip of this overlying this extensor digitorum brevis muscle. And the anterior tendon pathology that we may encounter, the same as any tendon pathology, partial or complete tears. What we can call complete tears can be called ruptures. They can often occur between the retinacular and their distal insertion. And when they tear and retract, it can be difficult to scan, and it can be quite a confusing picture. So definitely moving the toes when you're scanning those muscles, because they both, and tendons, because they both flex, well, they both extend the toes, but you need to flex and extend the toes to look at them. And always remember that there could be distal avulsions, but you can get tendinopathy, you can get tenosynovitis, and muscle herniations, remember that. Tibialis anterior partial thickness tears can be just messy to look at, and you need to make sure that you're not just having anisotropy, and you can dorsiflex the foot and invert the foot to have a look at this tendon. So just as a wrap up, what do we need to assess anteriorly? We should assess the joint recess, the anterior tendons, the AITFL, the interosseous membrane, the dorsal talonavicular ligament. When we're looking at this dorsal talonavicular ligament now, we can start to think of the deep peroneal nerve that will sit across that, and at that point is the area of entrapment that we may encounter with anterior tarsal tunnel syndrome. There's the anterior extensor retinacular, so there's the superior and inferior. There's our anterior tendons, and then the anterior neurovascular bundle, and we also talked about our superficial peroneal nerve. That's the end. I hope you found it helpful, and I hope that that has enlightened you to a bit more of the relative structures we can look at just in the anterior ankle. Thanks. See you later.